يلا بسم الله الرحمن الرحيم. السلام عليكم. Today we are talking about coagulation, homeostasis, and in this presentation there will be details regarding the physiology of coagulation, monitoring of coagulation, to coagulation. And here there is a statement: learn to be open-minded and respectful to people's opinions, even when you don't agree. From this statement, I can conclude that everyone has a special opinion and he has all the rights to respect his opinion, but this right does not give him a permission to disrespect opinions of others. In this presentation, there are plenty of international different opinions. I intentionally keep them as they are to make our minds more flexible. For example, in this presentation, you may find that the period of stopping, for example, clopidogrel before spinal anesthesia, neuroaxial anesthesia, in some tables just 5 days, in other tables maybe 7 days, and in other table maybe 9 days. For each time, there is a special opinion beyond this beyond this date, this time. We have to respect all. And from this statement, we have to learn always to focus on the similarities between different persons rather than the differences. Sometimes we hear a talk from certain body for 2 hours. From these 2 hours, you just focus on single statement that you disagree with this person. This is wrong and poor communication skills. You have to focus on the similarity with others, and then you can discuss the differences with them. In this presentation, there is overview regarding the hemostatic process, coagulation cascade, fibrinolysis, laboratory studies, and the drug affecting coagulation. And there will be answers for the following questions. What are the meaning of intrinsic and extrinsic pathways? Are all clotting factors proteins? يعني كل الكلوتينج فاكتور هي protein. What's the mechanism of action of warfarin? What's the cause of the delay in the onset of action of warfarin? What's the mechanism of action of protamine sulfate? And can protamine sulfate produce anticoagulant effect? It is used as antidote for anticoagulant, but can itself work as anticoagulant or has anticoagulant effect? What are the solutions to heparin resistance during cardiopulmonary bypass? What's the mechanism of action of heparin-induced thrombocytopenia? What's the role of warfarin in the management of heparin-induced thrombocytopenia? What's the role of platelet transfusion in the management of heparin-induced thrombocytopenia? What are the differences between standard and low molecular weight heparin? The answers of all these questions will be found in this presentation. And please, if you have any query about any of these questions at the end of this presentation, you can just alarm me. the purpose of hemostasis. The hemostasis to ensure that coagulation mechanisms are activated when there is injury and not activated when there is unnecessary purpose for this activation, means when there is no activation. So we have two important point overview. First, activation of coagulation factors when there is injury, and when there is no injury, to avoid unnecessary activation of the clotting factor or clotting systems. And another purpose, to restore tissue blood flow after repair of the injury. After the injury, there's activation of a clotting factor, and to restore tissue blood flow after the repair of this injury by a process known as fibrinolysis, we will talk about. Hemostatic process. These are three main steps. First one, primary hemostasis by local vasoconstriction and platelet plaque formation, and this can happen within 5 minutes. So it is the early process of coagulation. Second, secondary hemostasis, which is through the coagulation cascade, and this can occur within hours. And the third step, the fibrinolysis, that needs days to be occurred and completed. If we talk about first step, the platelet plaque formation, the vascular injury lead to release and binding of von Willebrand factor to the exposed blood vessel collagen. And this lead to glycoprotein IB to be on the platelet surface membrane bind to von Willebrand factor. Other factors play a role, thromboxane A2, that lead to vasoconstriction and platelet adhesion. And the last factor, adenosine diphosphate, that causes aggregation and activation of clotting factors. And according to the platelet activation and aggregation here, you find that the exposed endothelial surface, platelet exposed to collagen, lead to activation, release content of cytoplasmic granules, which are thromboxane and adenosine diphosphate. Thromboxane lead to vasoconstriction and increase ADP release from the platelet, and adenosine diphosphate per se accelerate platelet aggregation and activation. The second step, which is coagulation cascade, and we already mentioned that this to stabilize and reinforce the weak platelet plaque. The platelet plaque in the first step require the reinforcement and the stabilization by the coagulation cascade. And the coagulation cascade consists of 3 steps. First, formation of a prothrombin activator, conversion of prothrombin into thrombin, conversion of fibrinogen to fibrin. In this table, you are seeing all the coagulation factors and clotting factors here from 1 to 13. And you are seeing that the source of this factor mostly liver, but some of them also has another source or additional source. Like, for example, factor 5, in addition to liver, as another source, which is a platelet. Factor 8 as another source, which is lung capillaries. And you are seeing that most of the nature of this factor are protein. And the only difference is factor 4, which is an organic ion, calcium, which is calcium ion. And here the function of these factors. Here the coagulation cascade, you find that we have two important ways towards the end of coagulation process. The extrinsic pathway that mainly depend on factor 7 and tissue factor, and intrinsic pathway, which depend on several factors, 12, 11, 9, and here 10. So several factors play a role in intrinsic pathway. And here is the common pathway in any of intrinsic or extrinsic pathway, ended in the common pathway that lead to the formation of clot. The coagulation mechanism started by activation of clotting factors, and this requires a phospholipid surface either through the tissue factor, which is extrinsic to the blood from the injury walls, extrinsic to the blood. So according to this mechanism, we call this pathway by extrinsic pathway because it started extrinsic to blood from the exterior of the blood. Activated platelet factor 3 phospholipid, intrinsic to blood. This is from inside, from interior of the blood. So we call it intrinsic pathway. Vitamin K dependent factor, which are 2, 7, 9, 10. احنا نختصرها بالعربي نقول سنة 1972 لسهولة الحفظ. And formation of a reaction complex, we have a labile factors, which are factor 5 and factor 8. These are labile critical factors. Regarding factor 8, there are two sources of manufacturing of this factor. First, hepatic, and second, extrahepatic origin. It is synthesized in the vascular and glomerular endothelium in addition to sinusoidal cells in the liver. Absence of this factor leads to hemophilia A. Half-life of the factor 8, about 8 to 12 hours, and formerly referred as factor 8C. This factor consists of two important components with separate genetic control, which are factor 8R, which is the antigen of factor 8, and von Willebrand factor. This protein circulates in the bloodstream in an inactive form, bound to von Willebrand factor. It is bound to von Willebrand factor, so it is inactive. It is stabilized by association with von Willebrand factor to form factor 8 von Willebrand complex that require for the normal function of factor 8 in vivo. That is to say, the presence of von Willebrand factor enhance the normal survival of factor 8 inside our bodies. In response to injury, coagulation factor 8 is activated and separates from von Willebrand factor, and the active protein interact with another coagulation factor called factor 9. So the active form of factor 8 after the separation from von Willebrand factor, and the benefit of von Willebrand factor to stabilize the factor 8 in the period of no need for activation to increase survival rate of factor 8. The von Willebrand factor mediates adhesion of platelets to surface collagen. This factor has two important functions. First, mediate adhesion of platelet to the surface collagen in the first step of coagulation to form the plug, platelet plug. And also, this factor works as a carrier for factor 8C. Von Willebrand deficiency appears to have defect in the primary hemostasis and hemophilia. The deficiency of von Willebrand will affect two important steps of coagulation. First step of platelet plug, defect in the primary hemostasis that mediated by platelets, and also affect the second step, which is the coagulation step, and we call it hemophilia A due to deficiency of factor 8. Antithrombin 3, it is naturally occurring anticoagulant, prevent coagulation naturally in our body, irreversibly bind and activates thrombin and factor 8. This is the mechanism of action. It also inhibits factor 7, 9, 10, 11, and 12, but to a lesser extent. Accelerated by heparin manifolds. When we give the patient heparin, this factor activated many folds by heparin, and it is itself the main mechanism of action of heparin. Heparin has almost no anticoagulant action without antithrombin. Sometimes we give the patient heparin and there is no response, no effect of this heparin. Actually, because heparin itself has almost no anticoagulant action, and most of its action due to acceleration of antithrombin 3 by heparin to many folds. And when there is no response, means there is deficiency of antithrombin 3. Antithrombin 3 deficiency either congenital or congenital homozygous or heterozygous. In homozygous deficiency, there is a die in the infancy period. Why? Because there will be coagulation, thrombosis. Severe thrombosis lead to mortality during infancy. Heterozygous affect 85% suffer thrombotic event at age of 50 years. At the age of 50 years, those with deficiency in heterozygous type, there will be a thrombotic event at the age of 50 years. And also the deficiency can be acquired due to liver disease, DIC, malignancy, nephrotic syndrome, and malnutrition. What are the management of patient with antithrombin 3 deficiency requiring anticoagulant? Ali Nadam. What are the management of patient with antithrombin deficiency requiring anticoagulation?
العفو استاذ، عذرا انا هسه هوني تواصلت لان كان الانترنت ماكو، فيعني بديت بالانتي ثرومبين.
اوكي امير.
Barista.
What are the management of patient with antithrombin 3 deficiency requiring
نقدر نعوض لهم فريش فروزن بلازما واكو الترناتيف انتي كوابلنت.
نعم.
الفيردين والليبردين كلنا نقدر ننطق.
Good. First, fresh frozen plasma and heparin. ننطي وياه هيبرين. حتى يشتغل الهيبرين لازم عندنا انتي ثرومبين 3 اللي هو موجود بالفريش فروزن بلازما. او ننطي للمريض انتي ثرومبين 3 concentrate اذا available with heparin. Or we can use alternative anticoagulant. For example, عندنا several types of anticoagulant: dabigatran, milagatran, argatroban, pyridine. All these does not has any relation to the antithrombin 3, and we can use any of them in the anticoagulation step without any problem in the cases of antithrombin 3 deficiency. Here, the half-life of the coagulation factors, and I highlight some of them in red color as you find here. The factor 5, just 12 to 16 hours. Factor 7, the least, 3 to 6 hours. Factor 8, 8 to 12 hours. So these factors, with short half-life, and the deficiency of this factor can occur earlier than the factors with longer durations. The third step in the hemostasis, fibrinolysis, and this can be happened after the conversion of plasminogen to plasmin, lead to lysis of clot and the producing of fibrinogen degrading products and fibrinogen split products. Activation of plasminogen to be converted to plasmin can be either by endogenous substances through tissue plasminogen activator that release from the endothelium, or exogenous substances like streptokinase and urokinase, and tissue plasminogen activator that manufacture not natural like this one. And also there is plasminogen activator inhibitor. You have to differentiate between plasminogen activator and plasminogen activator inhibitor that inactivate tissue plasminogen activator and thereby control fibrinolysis. There are several causes for abnormally activated primary fibrinolysis, means not natural fibrinolysis after a case of bleeding and coagulation. Primary fibrinolysis, not preceded by plaque and coagulation and then fibrinolysis. Here, primary fibrinolysis, abnormally activated, that can happen in birth, prostate, and neurosurgery, cardiopulmonary bypass, and after streptokinase or urokinase therapy. What to prevent coagulation in normal tissue؟ يعني احنا normally هسه اذا ما عندنا مشكله ما عندنا coagulation. ليش ما يصير عندنا coagulation؟ ما يصير عندنا coagulation لانه اكو factors prevent coagulation which are normal blood flow, prostacyclin اللي work as a vasodilator and inhibition of platelet aggregation, antithrombin 3 that inhibit all factor except factor 7, protein C and S inhibit factor 5 and 8, and also tissue factor pathway inhibitor. All these factors prevent the coagulation in normal tissue. And here there is what is called virtuous triad of thrombosis that consists of 3 parameters important to trigger thrombosis. First, if there is endothelial injury, lead to thrombosis. Hypercoagulability lead to thrombosis. Abnormal blood flow lead to thrombosis. Here, abnormal blood flow lead to thrombosis, and here, normal blood flow prevent thrombosis, prevent coagulation. Anti-clotting mechanism, you find here the protein C with so sophisticated pathway here. The protein C
العفو أستاذ ممكن سؤال؟
اسمع.
العفو أستاذ بس الأنتي ثرومبين 3 يعني الأكسبت الفاكتور السابع لو الثامن العفو أستاذ؟
Except factor 7.
قبل شوي العفو ذكرنا أنه هو يشتغل السابع ما عدا الثامن ذكرنا يعني بالسلايد اللي قبله بالأنتي ثرومبين 3.
أنت حكيت ويانا ببداية المحاضرة؟
أي نعم موجود أستاذ.
بعدني من قلت راح تشوفون هنا اكو اختلافات بالمحاضرة وأنا متعمد أبقيها.
العفو أستاذ ما انتبهت هذه عليها صراحة.
أنا بأول سلايد بديت.
أول سلايد ما كنت حاضر أستاذ.
راح تشوفون اكو اختلافات وأنا متعمد أبقيها بس جايبها مصادر مختلفة. أريد أقول لكم أنه اكو different opinions in this presentation. وذكرت واحدة من المواضيع كلوبيدوغرين قلت راح تشوفوه بمكان to be stored 5 days وبمكان آخر 7 days وبمكان آخر 9 days.
ماشي أستاذ شكرا جزيلا.
Activated by protein C, activated by thrombin, thrombomodulin, and work as anticoagulant and fibrinolytic activity. Also, vitamin K and protein S are cofactors in its mechanism. Protein S also work as anti-clotting protein. Here there is a balance between hemostatic factors, different factors that have all of them opposing effect. In the anticoagulant factor, we find the protein S, protein C, tissue factor, plasminogen inhibitor, fibrinolytic system, and antithrombin 3. In the procoagulant, we have plasminogen activator inhibitors, antiplasmin, tissue factor, and clotting factor. The net result of all these factors, there is a balance in the normal person that this balance leads to activation of clotting after injury and no clotting during the normal life without the need of clotting in case of no injury. Now, we have to monitor the normal pathway if there is any abnormality in the body, any disease that affect coagulation, any use of the medications lead to interfere with coagulation. And starting by prothrombin time, which used to test both extrinsic and common pathways activity, and measures the vitamin K dependent factors activity اللي قلنا عليها 1972. This test can be done by adding thromboplastin plus calcium to the plasma that result in clotting time. Count the time for clotting. Normal value of thrombin time, 12 to 14 seconds. And there is what is called international normalized ratio. International normalized ratio. إيثار آيات، شنو international normalized ratio؟
السلام عليكم.
عليكم.
ما أعرف.
ما تعرفين؟ جود. بعد الصف الأول من حقك. بالنسبة للانترناشونال نورمالايز ريشيو احنا نستخدمها أكثر من البروثرومبين تايم، وبعض الأطباء أصلا ما حافظ قيمة البروثرومبين تايم لأنه ما يحتاجه، أكثر اعتمادنا هو على الانترناشونال نورمالايز ريشيو اللي احنا شلون يطلع لنا اياها أبو المختبر؟ يطلع لنا اياها لما يقيس البروثرومبين تايم وتطلع عنده الاكتوال فاليو مال البروثرومبين تايم. مثلا نفرض هاي طلع البروثرومبين تايم عنده على سبيل المثال 24 والنورمال فاليو الكنترول عنده 1.2، فراح العفو من قلت 24 اقصد 2.4 24 والنورمال فاليو اللي عنده هي 12. النورمال فاليو اللي عند الكنترول هي 12. فمن يقسم 24 على 12 ايش راح تطلع عندنا النتيجه؟ 24 على 12 راح تطلع 2. فنقول الاي ان ار of this patient هي 2 اذا كان الاكتوال هو 24 والكنترول 12. اذا الاكتوال طلع عندنا 18 والكنترول هو 12 يقسم 18 على 12 ايش راح يطلع؟ راح يطلع 1.5. فالنورمال اي ان ار accepted اي ان ار هي 0.8 to 1.2 while the recommended therapeutic INR according to the severity of the disease and the risk of thrombosis. So the targeted INR should be decided by the physician according to the risk of certain disease. Generally speaking, the recommended therapeutic INR is 2 to 3. The prothrombin time اللي هو lab investigation used for monitoring of comadine therapy. ايش نستنتج من هذا؟ انه to prolong PT we need a decrease in normal activity of factor 7 about 55%.
بس العفو استاذ، الصوت انقطع يعني حوالي السلايد اللي قبله وهذا بدايته يعني اختفى.
هذا السلايد شفتوه؟
يعني القبله وهذا يعني نهايه القبله وهذا ما شفناه. اذا امكن تعيد استاذ.
هذا مو حكينا، مو سمعتوه مال اي ان ار كملنا.
هذا اخر شيء استاذ.
اخر شيء سمعناه.
اذا نروح على السلايد الثاني. The prothrombin time, monitor comadine therapy. Comadine therapy include warfarin and other oral anticoagulant in relation to comadine. And it is most sensitive to alteration in factor 7 levels. And before prolongation of PT, has to decrease the normal activity of factor 7 about 55%. When there is a decrease in the normal activity of factor 7, less than 55%, there is no prolongation of PT. So this change in the PT time from normal to abnormal, relatively after big deficiency of the factor 7 in about 55%. After that, start the prolongation of prothrombin time. Another test, activated partial prothrombin time. This to test intrinsic and common pathway, dependent on the activity of all coagulation factors except factor 7 and factor 13. Normal value of this test, 25 to 35 seconds. And through this test, we can monitor heparin treatment, patient on heparin, and to screen for hemophilia. يعني نشوف المرضى نسوي لهم this test إذا أكو prolongation used for screening and discovery of hemophilic asymptomatic patients. And to do this test, saturated plasma added to surface activator on the phospholipids. And this test prolonged in patient on heparin, on thrombin inhibitors, and in case of increased fibrin degrading products. Prolonged only if coagulation factor reduced to less than 30% of normal. Means at the start of reduction in the clotting factor, there is no prolongation of partial prothrombin time. And after severe decrease to a lesser than 30%, lead to prolongation of partial thromboplastin time. Another test, activating clotting time, ACT. Monitor heparin anticoagulation in the theaters, mainly in cardiac and vascular surgeries. هذا التيست يمكن الوحيد اللي يسويه طبيب التخدير rather than the lab personnel. يعني احنا بنريد PT or PTT send the samples to the lab وننتظر النتيجة. الاكتيفيتنج كلوتينج تايم موجود بالثياتر على شكل جهاز بسيط وتيوب موجود. Aspirate blood, put it in the tube, put the tube in the device, تطلع لك القراءة مال ال ACT activating clotting time. يسويها طبيب التخدير نفسه in the theater بالcardiac surgery or in the ICU in post-cardiac surgery recovery period. In cardiac bypass, يعني during surgery, the ACT with at least more than 40 seconds after heparinization. يعني احنا in cardiac surgery طبيب التخدير يعطي heparin to induce anticoagulation, to induce it, to prevent coagulation. فقبل ما يروحون للكاردياك باي باس، قبل ما يوصلون للكاردياك باي باس، the ACT should be more than 400 seconds. فإذا انطينا هيبرين وسوينا ACT وطلع ال ACT less than 400 seconds, we have to give more heparin till reaching a reading of more than 400 seconds and tell the surgeon you can't go to cardiac bypass procedure. Normal value of ACT 90 to 120. At present, ACT is the most commonly used lab test to control heparin effect on extracorporeal membrane. Also, ACT results also dependent on the instrumentations. The result of ACT depend on instrumentation. I already mentioned that this depends on the device present in the theater or RCU. So the result depends on this device. Vary with the presence of hemodilution and hypothermia. The result affected by hemodilution and hypothermia. Thrombin clotting time, another test. Reflect abnormalities in the conversion of fibrinogen to fibrin, and this done by adding plasma to excessive amount of thrombin. It's prolonged in the use of heparin, thrombin inhibitors, low fibrinogen level, and in case of dysfibrinogenemia. The fibrinogen factor is normal in this case, but the function of fibrinogen is abnormal. This test also used to monitor pyridine and low molecular weight heparin, in which INR and PT may be normal or increased, and thrombin clotting time prolonged with adequate therapeutic levels. Another important test, Thrombo Elastography. In this test, there is continuous profiles during all phases of clot formation. So this is very important. Test can test and monitor all the phases of clot formation and look at the different profile according to different causes of defect in the coagulation process. Provide more accurate picture of in vivo coagulation process and used to evaluate hypo or hypercoagulable state, hemophilia, delusional coagulopathy, rare coagulation disorders, and anticoagulation treatment, coagulation problem with liver transplant. هذا الجهاز مثل ما حكيت لكم قبل شوية على التيست اللي نستخدمه بالكاردياك انستيزيا اللي هو activating clotting time، قلت لكم يستخدمه طبيب التخدير inside the theater and in the ICU for patient with cardiac surgery. هنا الثرومبو elastography device available inside the theater and in the ICU for the patient underwent liver transplant. In any patient with liver transplant, this device should be available in the theater and in the ICU post-surgery to monitor all phases of clot formation and to get accurate picture of in vivo coagulation process. And this device can provide us with continuous profile of all coagulation steps, continuous. It is discovered by heart rate in 1948 and used to monitor hemostasis as a whole dynamic process. Dynamic. Reflect changes time to time by seconds. Determine kinetics, growth, as well as the strength and the stability of the formed clot. Examine the interaction platelet and the protein together with a great number of dynamic activator and inhibitors. Here, as you see, the strength of a clot graphically represented per time as a characteristic cigar-shaped figure. This is characteristic cigar shape. And the R here, the R, this is R here, reflect the start of fibrin formation by platelet. And the K here, the K, this is the K, reflect coagulation time until trace amplitude about 20 millimeter, 20 millimeter. And this K represent the speed of clot factor growth, clotting factor growth. Here the function of platelet, and here the speed of clotting factor function. And there is also alpha angle. This is alpha angle. From the midline represent the acceleration kinetic of fibrin build up and the cross linking. This is between the midline and here the amplitude of the clotting factor formation. And this angle represents the acceleration of fibrin build up and the cross linking. The maximum amplitude, this is the maximum amplitude from here to here, represent number and function of platelets and its interaction with fibrin, both platelet and fibrin here. Maximum amplitude. And here, the maximum amplitude after 60 minutes from the starting of maximum amplitude. From maximum amplitude to 60 minutes here represent the stability of the clot. Here the stability of the clot, while here represent number and function of platelet and its interaction with the fibrin. All these parameters and results starting from R, K, alpha angle, maximum amplitude after 60 minutes, we can take idea about the coagulation profile, and also there is figure of this profile of coagulation, and we can compare the figure to the normal and abnormal figures. Already we know about different situations of coagulation. This is the normal figure, normal coagulation profile. And in case of thrombocytopenia, we can see this figure. And in severe platelet dysfunction, we can see this result. And in coagulation factor deficiency, we can see this figure. And in case of fibrinolysis, early fibrinolysis lead to this result. And in hypercoagulable state, we can see this figure. Also, another source of the shapes of different conditions, including normal, here, anticoagulant hemophilia, platelet blockers, means the patient on aspirin or clopidogrel. Here in DIC, we have two stages. The first stage with coagulation, second stage with bleeding. What is the mechanism of effect of Thrombo Elastography? شلون يشتغل الجهاز؟ We have heated to about 37 centigrade oscillating cup. Oscillating cup. This is the cup. Oscillating cup. And pin suspended from torsion wire into blood. This is torsion wire. And here the blood in the cup. And this is the pin. Development of fibrin strands, couple motion of cup to pin, this coupling directly proportional to clot strength. And the tension in the wire detected by electromagnetic transducer. Electrical signal amplified to create thromboelastogram trace. This is the trace. هذا التريس نشوفه either on the monitor or through printer. Result displayed graphically on pen and ink printer or computer screen. This is on the computer screen. Deflections of trace increases when clot strength increases and decreases as clot strength decreases. فلذلك تتغير عندنا according to the strength increases or decreases according to increase or decrease in the deflection of trace. Another test, bleeding time. Bleeding time used to monitor platelet function, and it is not a specific indicator of platelet function. Not very reliable. Why? Because very operator dependent. يعتمد على اللي يسويه. And variable from each institution. يختلف من مكان إلى آخر. Other factors play a role: degree of venostasis, depth and direction of incision. يعني احنا شلون نسوي فد انسجن بسيط. اذا هذا الدبث يكون يعني deeper ممكن يزيد البليدنج تايم. اذا الدايركشن اوف انسجن يكون باكثر من دايركشن ممكن يزيد البليدنج تايم. And this test, bleeding time, there is no evidence as a predictor of risk of hemorrhage, and it is useful indicator of efficacy of antiplatelet therapy. It is insensitive to mild platelet defect. This is maybe the last test. We call it a platelet function analyzer, relatively new global test of platelet adhesion and aggregation. The advantages of this test: it is non-invasive, simple, easy to perform, and it is very sensitive to detecting a platelet defect associated with von Willebrand disease. It is sensitive to diagnosis of acquired platelet defect, like when there is a patient on acetyl salicylic acid or non-steroidal anti-inflammatory drugs, or some dietary factors that interfere with coagulation, like excessive coca intake. It is also monitors pro-hemostatic treatment, like desmopressin and platelet transfusion. This test can be performed by aspirated blood in vitro from blood specimen into disposable test cartridges through a microscopic aperture cut into a biologically active membrane at the end of a capillary. The membrane of the cartilage are coated with collagen and adenosine diphosphate or collagen and epinephrine. These two are including a platelet plug to form which closes the aperture. Prolongation of closure means abnormality in the platelet function. Delimitation of this test inflexibility results should be interpreted in the context of either a simultaneously or recently drawn full blood count. Platelet count less than 80,000 or hematocrit less than 30% will prolong clotting time even if no platelet abnormality. Here, the different monitoring tests: bleeding time, prothrombin time, partial thromboplastin time, thrombin time, and here the component to be worked on: bleeding time in related to platelet function and vascular integrity, PT on the several clotting factors, and here the normal values of these tests. Now we reach the drug affecting coagulation, and before I'm talking about this aspect of the presentation, if there is any question or comment from any one of you, I am ready to answer.
العفو أستاذ، أنا بس كان عندي صار عندي انقطاع بالكهرباء والنت، بس عندي سؤال عن ال INR.
نعم تفضلي.
يعني بس إذا تقدر شوية تعيدنا. أي هو على INR، يعني صراحة شوية ما فهمت من شرحته.
بابا ال INR هو فتيست يعطينا ريدنج رقم. هذا الرقم حتى for simplicity ما نتعامل ويا هذا الرقم، وإنما نتعامل as a ratio of actual prothrombin time، الاكتوال الحقيقي اللي قسناه هسه، والستاندرد اللي موجود بالمختبر. فإذا كان الستاندرد الموجود بالمختبر هو 12 seconds for example 12 seconds اوكي وقسنا وطلع هم 12، ف 12 تقسيم 12 يطلع 1، فنقول INR 1 which is normal. مو صحيح؟
صحيح.
اذا سوينا تيست وطلع الاكتوال ريدنج مال المريض 24 والستاندرد مالتنا هو 12، 24 تقسيم 12 تطلع 2، فهنا الاي ان ار ايش راح تصير؟ راح تصير 2، يعني دبل ذا نورمال. مو صحيح؟ وياي؟
صحيح وياك اي دكتور.
اي فاحنا احسن من
اي نعم،
احسن ما نقول انه النورمال 12 واللي طلع عندنا 24. فور simplicity نستخدم انه الريشيو between الاكتوال ريدنج على الستاندرد ريدنج. يعني شلون نحصلها؟ نقسم الاكتوال على الكنترول او الستاندرد، على الكنترول او الستاندرد، وهذا يفيدنا مو بس بالاسسمنت، يفيدنا بالمانجمنت. فاحنا لما ننطي لمريض وورفرين فعندنا تارجت لهذا الوورفرين، ما نقول له روح اخذ وورفرين وقف. مثلا احنا نريد نقول نسوي الانتي كواجوليشن افكت يعني البرولونجيشن بالبروثرومبين تايم دبل. فايش راح نقول؟ نقول نريد الاي ان ار 2، نريد الاي ان ار 2. فاحنا المريض الطبيعي الكنترول النورمال بروثرومبين خلينا نقول هو 12، فنعطي وورفرين بحيث يوصل البروثرومبين اكتشوال بروثرومبين الى 24، معناها 24 تقسيم 12 يساوي 2، فالتارجت مالتنا صار الاي ان ار 2. مرات التارجت مالتنا حسب السيفيريتي والريسك انسيدنس نحتاج ان ار 2.5، مرات نحتاج اي ان ار 3، مرات المريض هو يجينا اي ان ار 3 واحنا نريد نسوي عمليه له ونحتاج ننزل الاي ان ار، فنقول نريد ننزلها مثلا to 1.5. فالتعامل دا يكون اسهل ويا الاي ان ار اسهل مما نتعامل ويا الريزلت الفاليو of the prothrombin time. Okay.
اوكي استاذ عشتي.
Any another question or comment? هسه وصلنا للثيرد part of this presentation. حكينا عن الفيزيولوجي، حكينا عن التيست and monitoring. هسه now we are talking about the drug affecting coagulation. فhere you see there is primary platelet plug formation inhibition by antiplatelet drugs, specific drugs, non-steroidal, acetyl salicylic acid, and there are a group of medication, IV anticoagulant, oral anticoagulant, affect the coagulation cascade, like the low molecular weight heparin, warfarin. And there are a group of drugs affecting fibrinolysis, like streptokinase, urokinase, tissue plasminogen activators. These drugs and these groups affect the normal coagulation process inside the body. Starting by antiplatelet agent, acetyl salicylic acid, and we have clopidogrel and prasugrel belong to thienpyridine, and we have the relatively recent groups, glycoprotein, which is a glycoprotein 2B and glycoprotein 3A inhibitor, like abciximab, or tirofiban. These medications, antiplatelet that affect the platelet, and here the site of action, which is تعرفون الاسبرين على الكوكس، وهنا الدايبيراديمول على الادينوسين، وهنا الابسكسيماب وجماعته على الجلايكوبروتين. الروute of administration, some of them oral, and the recent drugs by IV route. And here the plasma half-life, you find that some of them اللي هو ticlodipine 4 days, very prolonged. And here the metabolism either through hepatic or renal route, and this is the stopping of this drug prior to surgery. You find that aspirin need about 7 days here, while ticlodipine about 10 days, and some of them just 24 hours, like tiroban here, and also the diparidamol 24 hours. And the antidotes of them, some of them without non-antidote, and the tiroban may be antidoted or reversed by hemodialysis. the prostaglandin synthesis, this is the mechanism of prostaglandin, and you know that the aspirin work on cyclooxygenase, inhibition of cyclooxygenase that lead to the prevention of thromboxane formation, and the prevention of thromboxane lead to what? Decrease in the platelet aggregation according to a physiological mechanism already mentioned in the early slides of this presentation. Aspirin complete an irreversible block of platelet COX-1 in about 50 to 150 milligrams per day. The ability to aggregate restore in 4 to 5 days of stopping aspirin. شوف هسه على سبيل المثال هنا مكتوب 4 to 5 days ability to aggregate restore. قبل شوية احنا بالجدول كان مكتوب 7 days. اكو اماكن ممكن تشوفوها 9 days. 9 days. اكو بعض الاماكن تذكر 9 days. حنان ابراهيم.
نعم أستاذ.
شنو الفرق؟ ليش واحد يقول 5 days، واحد يقول 9 days، واحد يقول 7 days؟
ما أعرف صراحة، يعني ممكن حسب الميتابوليزم مثلا مع الدراكس أو.
نعم good. حنان اوكي. محمد طالب. محمد طالب ويانا؟
نعم استاذي. نعم استاذ.
شنو السبب محمد طالب؟
دكتور هو غير المفروض يعني حسب الهاف لايف مال البليتلت انه نحسبها.
حلو حلو
نعم.
حكيك حلو، حكيك حلو صحيح. فليش مرات يقول 5 مرات يقول 7 مرات يقول 9؟
ما اعرف دكتور.
عمر صلاح.
نعم استاذ.
عمر صلاح ليش مرات
نعم استاذ.
5 مرات يقول 9؟
دكتور يعني according لل يعني التايب مال السيرجري والاكسبكتيشن مال البلد لوزنج بالسيرجري، فعلى هذا الشيء يعني الوقت يكون فاري مختلف.
شنو الفرق اذا وقفنا 5 ايام واذا وقفنا 9؟ لان هو دا يسوي irreversible block of platelet.
اي استاذ هو غير يعني احنا يعتمد على العفو على الاكتيفيتي مالته، هو الدرج التايم مالته. مثلا هسه العفو الاسبرين 5 الى 8 ايام يخلص يعني الافكت مالته. ف according to type ما surgery اذا كان مثلا expected active bleeding بالسيرجري او major surgery يحتاج وقت اكثر حتى نسبه اللي اكتف الفانكشن مالها يرجع يعني نسبتها اعلى من النسبه يعني اقل.
اوكي I will clarify.
اوكي
I will clarify this.
نعم.
بس سمعوني شباب.
تمام.
الاسبرين induce complete and irreversible block of platelet. انتهى الموضوع. البليتلتس الموجوده كلها ما تشتغل بعد، وهاي البليتلتس لايف سبان مالتها about 9 days. 9 days. to retain a newly complete function of platelets, we need a new generation of platelets that are not affected by aspirin. فنحتاج إلى 9 days حتى هاي البليتلتس اللي already blocked by aspirin كلها ماتت وطلعت لنا new platelets. 9 days. لكن إذا اليوم احنا وقفنا الأسبرين فباكر راح تطلع new platelets، مو صحيح؟ هاي البليتلت not affected by aspirin. وعقب باكر ثاني يوم تطلع new platelets، وثالث يوم تطلع new platelets. فباليوم الخامس باليوم الخامس احنا تقريبا حصلنا تقريبا half platelets count are not affected by the effect of aspirin. فصار عندنا باليوم الرابع إلى الخامس نص البليتلتس ما تشتغل ونصها تشتغل. فاحنا بالنسبة لنا نعتمد على ال severity of bleeding, expected bleeding during surgery, type of surgery, major surgery, minor surgery, and to decide the need of platelet function. Is it complete platelet function? نحتاج نوقفه 7 إلى 9 أيام. Is it moderate platelet function? نحتاج نوقفه 4 إلى 5 أيام. فمن واحد يكتب لك 5، واحد يكتب لك 7، واحد يكتب لك 9. اكو scientific idea beyond this decision and number of days to be stopped before the surgery. The effect of aspirin has primary prevention when 10 years risk of vascular event more than 10%. يعني use as a prophylactic. المريض ما عنده MI ischemic heart disease وما عنده stroke، بس ممكن أن نعطيه prophylactic in case of 10 years risk of vascular event more than 10%. or secondary prevention. المريض صار عنده ischemic heart disease or stroke فنعطيه aspirin that decreases the recurrence of MI in about 30% and stroke in about 25%. Given lifelong after coronary or cerebrovascular event, up to 300 milligram per day alone, not contraindicated for regional anesthesia. لما نقول not contraindicated معناها not absolutely contraindicated. Not absolutely contraindicated. بس ممكن أنه يدخل بالrelative contraindication. Actually, regarding the neuroaxial anesthesia, neuroaxial, هم كانوا حاطين بالrelative contraindication، شالوه الآن. لكن احنا شو وقت نسوي neuroaxial anesthesia؟ نسوي neuroaxial anesthesia لما اكو surgery. فاحنا الموضوع ما ناخذه from just a neuroaxial anesthesia aspect of view، وانما احنا عندنا عمليه وهي العمليه يصير بيها bleeding. ف this decision has to be taken from two aspects of view. First, neuroaxial anesthesia itself that can induce epidural hematoma, and second, regarding the bleeding during and after the surgery. Here the other types of non-steroidal anti-inflammatory drugs, and this is the prior days or hours of stopping before procedures. And you see here the piroxicam 10 days and the celecoxib no need to be stopped before surgery. And in between we have indomethacin, ketorolac about 2 days, ibuprofen about 1 day. Clopidogrel. It is a platelet ADP receptor antagonist, loading dose about 300 milligram, then to be continued on 75 milligram per day. Decreases risk of MI in unstable angina about 18%, and in patients with coronary stent that can develop thrombosis, stroke, recurrence about 30%. Half-life about 4 hours, and recovery from a drug effect takes 7 days. Here mentioned 7 days. Irreversible platelet inhibition. بسبب irreversible platelet inhibition. Not belong to the half-life of this drug, but because its effect is irreversible on a platelet. Relatively contraindicated to neuroaxial block, still relatively contraindicated in a neuroaxial block. Resistance to antiplatelet might be cause of recurrence of thrombosis, and this related to gene polymorphism. Here are several types of antiplatelets, and here the half-lives, the duration of platelet inhibition. Look at aspirin, clopidogrel, permanent. And we need the new generation of platelets to get good platelet function. And here the recommended time for discontinuation before the surgery. Mentioned 7 to 10 days. Now we are talking about anticoagulant, and the classification. We have heparin, low molecular weight heparin, like deltaparin and enoxaparin, nadraparin. And also we have oral anticoagulant like warfarin, and the newer anticoagulant, argatroban, dabigatran, and other nilagatran. All these are known as direct thrombin inhibitors, which is the newer anticoagulant. Their effect through thrombin clotting factor. And in this table, the different types of the anticoagulant. This is heparin, unfractionated heparin, and this is low molecular weight heparin, streptokinase, oral anticoagulant, warfarin. The site of action, here factor with heparin factor 2 and 10, with the low molecular weight heparin mainly factor 10, strepto and tissue plasminogen through plasminogen itself, and oral anticoagulant via vitamin K dependent factors. Route of administration, plasma half-life, excretion method. Here, the period for stopping before the surgery. And you can see that the heparin needs just 6 hours, while the oral anticoagulant mentioned here, 2 to 4 days. Actually, we need more than 4 days, sometimes 5 days or more to get rid from the effect of warfarin. Here the monitoring screen. For example, some of them prothrombin time, partial thromboplastin time affected, like in heparin, نشوف إنه اللي affected هو partial thromboplastin time, but prothrombin time not affected. Already we mentioned that. And for warfarin, opposite. Prothrombin time affected, partial thromboplastin time not affected. For low molecular weight heparin, both of them are not affected. We cannot rely or depend on prothrombin time nor partial thromboplastin time. And this is the anticoagulant of these drugs. The heparin can be, the antidote, reversal agent. For example, heparin can be reversed by protamine sulfate. Protamine sulfate cannot reverse low molecular weight heparin completely. Regarding oral anticoagulant, vitamin K or factor 7, plasma, fresh frozen plasma, prothrombin complex concentrations, different reversal of warfarin. Here the other newer anticoagulant, and here the prior period to be stopped before surgery, and you find that the route of administration of all of them by parenteral route through IV administration, and here the effect of these drugs on PT and PTT, and here the antidote of dengue. Warfarin, it is vitamin K active. I mean, talking about the mechanism of activation of vitamin K dependent factor. Vitamin K activate these factor by adding carboxyl group. Warfarin inhibits synthesis of vitamin K dependent factor, and in addition protein C and S by prevention of gamma carboxylation of these factor. يعني prevent this step, adding carboxyl group. Warfarin prevent vitamin K from carboxyl, adding carboxyl group, prevent carboxylation of these factors. By competing vitamin K on its binding site, warfarin compete vitamin K on its binding site on hepatocytes داخل خلايا الكبد where the carboxylation occurs. All the process of warfarin inside the hepatocytes. What's the cause of the delay in the onset of action of warfarin? Because the existing clotting factors already activated by vitamin K, and the warfarin would compete for the next vitamin K action. يعني القديم هو أصلاً يعني well synthesized and functioning well. فمن نعطي warfarin نحتاج أنه تطلع a new clotting factor not carboxylated by vitamin K, فلذلك ما راح تشتغل. This need a time about 5 days to work well. شلون نعرف اشتغل لو ما اشتغل؟ نعتمد على البروترومبين تايم والاي ان ار اللي قبل شويه حكيناها. قلنا ننطي الورفرين ونراقب الاي ان ار، واحنا ببالنا اكو تارجت فور اكزامبل اي ان ار 2، فننطي الورفرين ونراقب الاي ان ار الى ان توصل لل2. ذاك الوقت نبقى على المينتننس مالتنا مال الورفرين. Reversal of warfarin, stopping medication and waiting for 4 days. نوقف للورفرين وننتظر 4 days ونسوي بيتي ونشوف الاي ان ار رجعت طبيعي او ما رجعت طبيعي. او ننطي فيتامين كي بيرورال اور اي في، واذا كانت الكيس امرجنسي ونريد نسوي عمليه والمريض على وورفرين، فهنا نعطي فريش فروزن بلازما 1 to 2 units in a dose of 5 to 8 ml per kg. طبعا البعض يبالغ يعني من خلال البوست كول ميتنج من اشوف الطلبه قسم ينطون من كيفهم 3 units 4 units. يعني you have to keep in your mind that why this patient on warfarin to prevent clotting. فاحنا هسه من نريد نوقف الايفكت اوف warfarin على الاقل الرجعه للطبيعي، بس ماكو داعي نعطي مور كلوتنج فاكتور. اذا اعطينا اكثر كانما احنا induce clotting, induce coagulation. ف don't exaggerate in the giving of fresh frozen plasma. Just give a normal dose for reversal اللي هي 5 to 8 ml per kg، تطلع about 1 to 2 units of fresh frozen plasma. وممكن واحد يعطي يعني other alternatives. احنا الموجود عندنا fresh frozen plasma but there are alternatives اللي هي factor 7 or prothrombin complex concentrate. Check PTI and INR prior to surgery. Indication of warfarin, treatment of arterial and venous thrombosis, prevention of thromboembolic diseases like thrombophilia, patient with arterial fibrillation liable for thrombosis and embolism, patient with mechanical heart valve, and patient at high risk of surgery. Dose of warfarin, 5 to 10 milligrams per day, loading dose, affected by many drugs and dietary variation. راح ناخذها بعدين بجدول نهاية هذا الموضوع. The drugs and dietary variation that affect the normal work of warfarin requires 2 to 7 days to reach therapeutic levels. For immediate anticoagulation, begin with heparin. هذا الموضوع انه احنا نحتاج immediate anticoagulation. اذا انطينا وارفرين نحتاج تقريبا 5 ايام حتى يشتغل، واحنا نريد immediate anticoagulation. فشو نسوي؟ ننطي الوارفرين and in the same time نعطي الهيبرين. فاللي راح يشتغل بالبدايه الهيبرين، نبقى نعطي هيبرين ووارفرين الى ان يشتغل الوارفرين after for example 4 5 6 days. من نشوف اشتغل، شلون نعرف اشتغل؟ باي INR and PT. نقطع الهيبرين ونستمر على الوارفرين. نفس الموضوع ممكن نسويه ان فايس فيرسا. لما هو المريض على وارفرين واحنا نريد نوقف الوارفرين حتى يروح الافكت مال الوارفرين نحتاج 5 ايام. احنا ما نريد نبقي هذا المريض at risk for 5 days. فممكن انه نضيف الهيبرين ونوقف وياه الوارفرين. فهاي الفتره اللي دا يقل الافكت مال الوارفرين الهيبرين دا يشتغل بروبرلي الى ان يخلص الافكت مال الوارفرين. فنقطعهم، نقطع الهيبرين ونسوي العمليه. شو وقت نقطع الهيبرين؟ نقطعه قبل 6 hours before the surgery. تارجت INR، اكثر من واحد سالني على INR. قلت لكم احنا التارجت احنا نحدده، فممكن يكون 2.5 INR بالبيشنت اللي يكونون liable for venous thromboembolism or pulmonary embolism or patient with arterial fibrillation. ممكن يكون التارجت up to 3.5 in the patient with the prosthetic heart valves. Warfarin teratogenic and not to be given in first trimester of pregnancy, but there is an opinion just to consider it. خلوا ببالكم، مو شرط تأمنون به، بس خلوا ببالكم عرفوه يعني. لكل كيس إلها advantage disadvantage. إنه lowest risk of valve thrombosis versus heparin. يعني with warfarin lowest risk of valve thrombosis versus with heparin. And this explains the use of oral anticoagulant throughout the pregnancy حتى يقلل الريسك of valve thrombosis. This is associated with warfarin embryopathy in just 6.4% of live birth. This was with less than 9.2% risk of valve thrombosis. يعني احنا اللي نحولهم على هيبرين عندهم risk of valve thrombosis 9.2 وعندهم risk of embryopathy about 6.4. فلذلك احنا يحتاج ان نسوي advantage and disadvantage to continue warfarin and accept this incidence of embryopathy, or to stop warfarin and accept this incidence 9.2 of risk valve thrombosis. Here the several medications affect the normal action of warfarin. ممكن عليه كيفكم تشوفوها بالبيت لأنه وقت المحاضرة طال، بس أنا ذكرت لكم اكو هواية drugs affect the action of warfarin، فممكن تقروها على كيفكم. And warfarin has biphasic effect on PT and INR. Initial one, initial increase بالPT, initial increase بالPT by decrease factor 7 اللي هو shortest half life to 55%. يعني أول مرة يزداد الPT بسبب decrease in factor 7. After that increase بالPT بسبب decrease in factor 2 and factor 10. And this is the therapeutic anticoagulant effect. Discontinuation return to normal، يعني بالعكس راح يصير أول مرة factor 7 return to normal لأنه the duration of effect of factor 7 short duration، فلذلك راح يرجع earlier followed by factor 2 and factor 10. Now we will talk about unfractionated heparin. Heparin is a negatively charged, water-soluble, sulfated glycosaminoglycan composed of altering uronic and glucouronic acid residues. Commercially prepared are isolated from porcine intestinal mucosa or bovine lungs. Commercial preparation of heparin. There are heterogeneous mixtures of polysaccharide chains ranging in molecular weight from 3 to 30,000. The molecular weight ranging from 3 to 30,000. Mode of action of heparin, it is bind and increase antithrombin 3 activity to 1,000-fold, lead to binding and inactivation of factor 2 and factor 10. Degree of inhibition of factor 2 and factor 10 is equal, while with low molecular weight heparin, the inhibition of factor 10 more than that of factor 2. With lesser inhibition here of factor 11 and factor 12, in vivo variation in response to a fixed dose of heparin occurs between individuals. Pharmacokinetic limitation of heparin caused by the binding of heparin to plasma protein lead to heparin resistance state. Heparin resistance state means there is decrease in the effect of heparin. Indication, prevention of venous thromboembolism, treatment of venous thromboembolism, in patients with acute coronary syndrome, surgery in cardiac bypass. Already I mentioned to you that heparin given intraoperatively for patients with cardiac surgery, وننتظر ال ACT test increase more than 400 and tell the surgeon to start the bypass cardiac surgery. We can use it in low dose, 5,000 units subcutaneously every 12 hours for thromboprophylaxis. Peak effect after 40 to 50 minutes, duration about 4 to 6 hours, low risk of hemorrhage during anesthesia or surgery with such dose, with such dose, prophylactic dose, and the heparin does not cross blood-brain barrier or placenta. The standard dose, we were talking about low dose, and the standard dose, regular doses for therapeutic anticoagulation start by 50 to 100 units per kg per hour. Then 15 to 25 units per kg per hour. Our target of PTT 1.5 to 2 times. يعني normal PTT prolonged to 1.5 to 2 times حتى يكون accepted therapeutic according to our decision. This associated with high risk of bleeding during and after surgery. So must be stopped at least 6 hours before surgery and restarted about 12 hours post-operatively if needed with close monitoring by partial thromboplastin time. And if we want immediate reversal of heparin, this can be done by protamine drug. In cardiac bypass قلت لكم نعطي الهيبرين نعطيه 3 ملغ per kg and to prevent extracorporeal clot formation with repeated doses to maintain ACT more than 400 seconds. Prevent over administration of heparin إذا أعطينا أكثر من طبيعي will lead to hemorrhagic consequences, particularly during post-operative or in the setting of cardiac bypass surgery, and to consider alternative therapy. Side effect: hemorrhage, osteoporosis, hypersensitivity, heparin resistance, and heparin-induced thrombocytopenia. Can we use fresh frozen plasma to antagonize heparin? How we can treat heparin resistance? أخذناها in the last presentation. It is a source of antithrombin-3, so it potentiates the action of heparin. The antidote of unfractionated heparin is a protamine sulfate. And regarding the second question, it may result from low antithrombin-3 and can be treated with fresh frozen plasma. Protamine sulfate. Here the picture of salmon. And sorry if any one of you like salmon and now we are fasting. Sorry for this stimulation. Protamine sulfate. It is manufactured from the sperm or mature testes of fish of the genera Salmo or Truta or Oncorhynchus. Protamine sulfate 1 milligram per 100 units of heparin. يعني as antidote نعطي 1 ملغ لكل 100 units of heparin. It binds and neutralizes the heparin. ليش؟ لأن هو positive charge portion and bind to negative charge portion of heparin. فالنتيجة will neutralize the heparin and stop its effect. Excess protamine has anticoagulant action, 1% of that of heparin. And this is the answer of one of the questions in the first several slides in this presentation. Side effect of protamine sulfate: hypotension, pulmonary hypertension, bradycardia, and anaphylaxis. These side effects are immune-mediated and idiosyncratic. يعني idiosyncratic unrelated to the dose. احنا بنعطي البروتامين usually we give it slowly to avoid hypotension, pulmonary hypertension, bradycardia and anaphylaxis. فبنعطيه slowly with monitoring of blood pressure and the breathing of the patient, auto saturation, heart rate. Patient at risk for this side effect, those allergic to salmon or patient vasectomized male and a prior exposure with sensitization. Solution to heparin resistance during cardiopulmonary bypass. يعني إذا patient عنده heparin resistance وإحنا المريض نريد نسوي له cardiac surgery. فهنا ممكن نستخدم النيور انتي كواجولانت راح تكون effective بدلا عن الهيبرين. Heparin induced thrombocytopenia caused by heparin dependent immunoglobulin G platelet antibody interaction with the platelets and platelet activation and aggregation lead to arterial and venous thrombosis. We call it white clot, because this is due to a mixture of platelets and fibrin. It is suspected when platelets less than 100,000 per microliter or there is tachyphylaxis. Tachyphylaxis means giving of normal dose of heparin without effect. Tachyphylaxis, no effect, or decrease the effect. And in case of thrombosis, in any of these three important events, ممكن نقول احنا in a case of heparin-induced thrombocytopenia. And this can appear after 7 to 10 days after administration of heparin for patient not exposed previously. Not exposed 7 to 10 days. If exposed previously, can occur dramatically for exposed. After exposed مباشرة, directly. This condition lasts 4 to 8 weeks, up to 3 months. Elective cardiac and vascular surgery should be delayed, postponed, and urgent cardiac surgery by non-heparin strategies اللي حكينا عنها. ممكن نستخدم النون-heparin لنيور anticoagulant. The management of heparin-induced thrombocytopenia is not sufficient to simply discontinue the heparin administration. Generally, an alternative anticoagulant is needed to suppress the thrombotic tendency while the generation of antibodies stops and the platelets count recover. يحتاج هاي المدة an alternative anticoagulant منطقي. These alternative ممكن يكون الأرجاتروبان أو other newer anticoagulant because warfarin should not be used in this situation until the platelet count is at least 150,000 because there is a very high risk of warfarin necrosis, skin gangrene due to warfarin. فهبرين ما نقدر نعطي، وارفرين ما نقدر نعطي، نستخدم النيور anticoagulant. The question, can we give a platelet or not? هسه هبرين ما نقدر، وارفرين ما نقدر، platelet ممكن نعطي لو ما نعطي. هسه راح تجينا بعد شوي. If the patient was receiving warfarin at the time when heparin-induced thrombocytopenia is diagnosed, the activity of warfarin is reversed with vitamin K. Transfusion platelet is discouraged as there is a theoretical risk that this may worsen the risk of thrombosis. the platelet count is rarely low enough to be the principal cause of significant hemorrhage. فيقول لك لا تعطي platelets لأنه ممكن يسوي worsening بالrisk of thrombosis, and at the same time rarely أنه the platelet count is low enough to induce significant hemorrhage due to platelet decrease. Now about low molecular weight heparin اللي هو 4 to 6.5 thousand daltons versus the standard heparin اللي قلنا عليه 3 to 30 molecular weight daltons. Retain anti-factor 10 activity mainly, less anti-factor 2 than that with unfractionated heparin, enhance antithrombin 3 interaction with factor 2 and factor 10, degree of inhibition of factor 10 more than that of factor 2. Here, there is several drugs of low molecular weight heparin, and here the ratio of inhibition of factor 10 to factor 2 different between several types of low molecular weight heparin, and this is in comparison with the standard heparin, which has equal effect on factor 10 and factor 2. And here the half-life of the several drugs in this table, and comparing with unfractionated heparin, the low molecular weight heparin with longer duration of action if given and given subcutaneously, better bioavailability, about 70 to 90%, in relation to that of unfractionated heparin, 20 to 30%, and the assay factor is factor 10 level. It is gold standard for surgical thrombotic prophylaxis. يستخدموه to prevent thrombosis perioperatively. طبعا هنا different standard شوي الوقت ضاق راح I will skip some not essential slides like this one اللي هو different regime of using low molecular weight heparin to prevent thrombosis, and here also in relation to the prophylactic, using as prophylactic in several types of surgery. The comparison between standard heparin and low molecular weight heparin, حكينا على الموليكولار weight والbioavailability. المونيتورنج راح نشوف انه الهيبرين adjusted according to PTT, while he no need for monitoring, no need for those adjustments according to taste. The half-life, low molecular weight 4 to 6, while hours, while here variable dose dependent, and the clearance in standard heparin hepatic, low molecular weight renal. Effect on platelets ممكن يسوي لنا هنا heparin induced thrombocytopenia. Here lower incidence of heparin induced thrombocytopenia, less inhibition, no interaction. Risk of bleeding higher with heparin, lower with low molecular weight heparin. We already talked about the effect on factor 10 and 2, and the reversal for heparin standard by protamine, and for low molecular weight heparin only anti-2, 90%, but not anti-10, total factor 10, 60% activity reversed by protamine. 1 per 100 units of anti-factor 10 units. cost inexpensive standard heparin and more expensive below molecular weight heparin. What's the proper duration to stop the following medications before neuroaxial anesthesia? هذا question. Question الثاني. What's the proper duration to restart them post-operatively? What are these medications? Antiplatelets, aspirin, clopidogrel, and abciximab, warfarin, heparin, low molecular weight heparin. The answers of the two questions for all these medications موجودة بكل الكتب، بس أنا شفت أكو simple table قلت أكتبه لكم وجوز تستفيدون منه in the Oxford Handbook of Anesthesia. أكو simple table summarize the answers for all these questions for all these drugs. Here another table for the minimum delay regarding the removal of epidural catheter and in after placement or removal of epidural catheter. تشوفوه على كيفكم. هذا يختلف عن الجدول اللي قلت لكم عليه بالأوكسفورد هاندورك، بس ضفته هنا حتى تشوفوه. وهنا recommended management of patient on regular or oral anticoagulant إذا كان low risk أو high risk شنو الرجيم اللي نسويه. إذا patient على antiplatelets الalgorithm of management هنا. عندنا last topic هو Anti-Fibrinolytic for Hemostasis اللي تتضمن إبسيلون أمينوكابرويك أسيد، synthetic أمينوكابرويك أسيد، tranexamic أسيد، أبروتينين، ديسموبريسين. tranexamic أسيد كلكم شايفين نستخدمه احنا بالعمليات. الإي أمينوكابرويك أسيد mechanism prevent activation of plasminogen to plasmin. Dose 50 mg per kg per oral or IV. Uses the primary menorrhagia, oral bleeding. يعني نستخدمه to decrease or stop bleeding. Bleeding in patient with thrombocytopenia. Blood loss during cardiac surgery. Side effect GIT, toxicity, and thrombi formation. A protein used to decrease perioperative blood loss. The exact mechanism is unknown, but it is maybe due to plasmin-mediated mechanism. It maintains the platelet adhesiveness by preventing plasmin-mediated degradation of platelet glycoprotein. اكو فد شيء اسمه recombinant factor 7 ما اعرف سامعين بيه او ما سامعين بيه، يستخدموه بالحالات اللي يصير بيه bleeding. فالميكانيزم activate coagulation system through extrinsic pathway. It enhance the tissue factor pathway, bind loosely to platelets and directly activate factor 10 that lead to increased thrombin generation with factor 5 presence. Never completely normalize thrombin generation, but enhance hemostasis. Dose 1.2 mg per vial, 90 microgram per kg every 2 hours. Adjust as clinically indicated. FDA approved for use in factor 8 inhibitors. يعني إذا أكو factor 8 inhibitors المريض هيموفيليا ومن نعطي factor 8 أكو inhibitors راح يتميز الإفكت of this factor 8. شو نسوي؟ إنه ال FDA approved the giving of factor 7. الفاكتور 7 كأنما دا يستخدم alternative path for coagulation hemostasis. لكن اللي لاحظ انه اكو اوف ليبل يوز، يعني on non-scientific base، ممكن يكون له effect بس هو not approved by FDA. يستخدمون component factor 7 إذا البيشنت عنده liver disease, liver transplant, trauma, and if there is platelet disorder or in case of intracranial hemorrhage. Surgery or trauma with profuse bleeding. Consider in patient with excessive bleeding without apparent surgical source and no response to other components. And anticoagulation therapy with bleeding. يعني البيشنت على anticoagulation وعنده bleeding ممكن نستخدم الفاكتور 7 in these two clinical conditions. At the end of this presentation, thank you very much. If there is any question or comment, I will be happy to hear from you and try to answer you.
أستاذ، بس بالنسبة للأسئلة اللي بالبداية مكتوبة، أكو سؤال all clotting factors.
صوتك شوي صوتك.
أستاذ أكو سؤال all clotting factors are proteins.
نعم.
إحنا قلنا بس الفاكتور 4.
صحيح.
ماكو غيره يعني؟
لا. Up to my knowledge ماكو غيره.
يعني بس فاكتور 4. زين أستاذ شنو هو يعني النيتشر مالته؟ ايون ماشي اوكي. ها هي شكرا استاذ.
استاذ بالنسبه لموضوع الهيبارين انديوست ثرومبوسايتوبينيا، ذكرت انه يصير تاكيفيلاكسس وقلت انه هو يعني need more drug doses to get the يعني the same effect. زين هو شنو هو الفرق اللي يعني التاكيفيلاكسس عن التوليرانس؟ يعني هم يشابه التعريف مالته.
صحيح، بس التاكيفيلاكسيس occur in short period.
شكرا. بس هذا الفرق؟
نعم.
short period.
راح ناخذها بالتفصيل بالمحاضرة مال ومحاضرة أنا أقدمها اللي هي General Pharmacology.
عشان إيدك دكتور، شكرا.
أكو بعد سؤال؟ Thank you very much. احنا بنهاية شهر رمضان وقريبين على العيد، أتمنى لكم عيد سعيد وإن شاء الله تحقيق الأماني للجميع. كل عام وأنتم بخير، ونشوفكم إن شاء الله دائما بأعلى المستويات. في أمان الله.
شكرا
استاذ.
سلام.
مع السلامة.
مع
الف خير.